ان شاء الله وكده.
Bismillah ar-Rahman ar-Rahim. Another new meeting of Egyptian Society of Nephrology and Transplantation online CME meeting. Welcome everyone in this new meeting. And today we have our monthly or near monthly ESNT clinical forum, which we discuss usually cases coming from different Egyptian institutes, universities, and hospitals. Today, we are in date with Forum-Menoufia University, Forum-Menoufia University team under the leading of Professor Said Khamis, the head of nephrology dialysis unit in Forum-Menoufia University. As usual in this clinical forum, we are honored to have Professor Muhammad Subh as the great moderator and the main moderator of this clinical forum. And we are honored by him with us today. Professor Muhammad Subh, as you all know, Professor of Internal Medicine and Nephrology, Mansoura University, and Mansoura Nephrology and Dialysis Center. He is the winner of the Prize of Science, and he is one of the well-known nephrologists all over the world, Africa, Arabic world, and of course in Egypt. We are honored usually to have Professor Subh in this meeting, and with his support, continuous support to us in this platform, usually by his shared comments and discussions, and usually encouraging me, especially, and encouraging all of us to continue in this way. And the second moderator is the head, as I have said, of the Forum-Menoufia University, Professor Said Khamis, which will be introduced by Professor Subh this night. So I will leave them the floor for Professor Subh to start the meeting, and later on for Professor Said Khamis to introduce his students one by one, to introduce their cases and enjoy this surely highly scientific session with highly scientific cases, well prepared, and enjoy the discussion and informations contained within it. Professor Subh, please.
Okay, thank you. First, also, I'd like to thank my dear friend, Dr. Yasser Abdel Hamid, Professor Yasser Abdel Hamid, for his continuous activity, help to all members of our society, Egyptian Society of Nephrology, leading this era of continuous medical education. I would like to express my thanks to him for his great effort.
Thank you, my good professor. Thank you so much.
Thank you. Today, it will be a great day. My friend Said Khamis, I know him very long time ago when he started specialty of nephrology. Since that time, he is always keen and eager to go up and up in standard levels. He always enthusiastic, always digging hard, and even his prints on the continuous medical education activity in this society is very clear. He is very supportive, very scientific to our young nephrologists, and even to us. He is continuously presenting new cases, new information on the side, on the teaching side of this Society of Nephrology. I always observe the young generation in Menoufia University Renal Unit. Actually, Dr. Said is lucky to have this high quality doctors around him, and I expect he will succeed to make a great move in his unit. It will not, I think, in the future, it will not be only nephrology and dialysis unit. I think he is thinking, and he started to plan for transplantation program, and all of us will be behind him for this noble objective. I'm sure today you will see a good scientific day. So I will ask Dr. Said to introduce his colleague now.
Thank you, my dear professor, my dear role model, Professor Muhammad Sobh. It's a great honor to me to be with you today and every day. And in the meantime, I don't deserve all the sweetie statements you mentioned about me. But actually, thank you so much for you. And thank you also for my dear friend, Professor Yasser Abdel Hamid. And inshallah, we hope that this meeting will be fruitful and for all by our young generation of great speakers, inshallah, in the future. Let us start, if you allow me, Professor Sobh and Professor Yasser, with my young daughter, or say my daughter, Heba, Dr. Heba Said Asim. Dr. Heba is assistant professor of internal medicine and nephrology at Menoufia University. And in the meantime, she is very polite, and in the meantime, very scientific. And inshallah, she will be one of the great figures sooner in the community, in the nephrology community in Egypt. Please, Professor Heba, can you start your talk, please, if you don't mind?
Thank you, Dr. Said. I express my honor to Dr. Said to give me this chance to be between my staff of nephrology, to Muhammad Sobh, Dr. Yasser, and everyone of the audience. We will present a challenging case presenting with rapidly progressive glomerulonephritis. We will start. Our case is a 32-year-old female patient, married with 3 offspring. The youngest is 4-year-old housewife, no special habits of medical importance. In May 2022, she alleged recurrent itch skin eruption all over the body that was relieved by intramuscular dexamethasone injection, about 7 ampoules within 1 month in a private facility. But in October 22, she developed a recurrent attack of wheezy chest, shortness of the breath, dry cough that resolved with atropine, pulmicort, nebulizer, diuretic, and mentolocust. 7 days later, she complained from hematuria, generalized fatigue, and she asked nephrology consultation, who recommended the following investigation, which relieved complete blood pictures, anemia, showing anemia. Albumin creatinine ratio was 440 milligram. Urine analysis showing albumin +1 and RBCs over 100 with positive dysmorphic RBCs. Serum creatinine was 1.8 milligram per deciliter, serum albumin 2.5 gram per deciliter. And the immunological workup was negative. ANA or anti-double strand or ESR was 90. And renal biopsy was recommended. So the patient underwent renal biopsy outpatient in 18 February 2023 at the Department of the Interventional Radiology in the Liver Institute. But after 1 week from the renal biopsy, the patient admitted to our department by anuria, generalized fatigue, and repeated vomiting. She denied any history of epistaxis, nasal incrustation, or chronic sinusitis. On examination, a wheelchair bound extremely very sick and pale patient. She was conscious, oriented to the time, place, and person. Vitally was stable, normal blood pressure, heart rate, respiratory rate, and temperature. On the examination, feel chest showing scattered wheezy, and there is marked hair loss, but the other system review was correct. Laboratory investigation in ER was serum creatinine about 23 milligram, urea 327, and serum potassium was 7.5, and severe metabolic acidosis with high anion gap, and she admitted to our department and underwent emergent hemodialysis session. And then laboratory in the ward is showing microcytic hypochromic anemia with leukocytosis, which is showing an eosinophilia with 11%. ESR can 70, and the C ANCA negative, B ANCA was negative, LDH with haptoglobin was normal, and normal C3 and C4 level. Serum albumin was 2.8, normal sodium and potassium post dialysis, and the corrected calcium was 7.9. The radiological was normal, ultrasound can be average type was kidney, with echo and CT chest was normal. We're thinking about the case, and there is the first provisional diagnosis as an RPGN, most probably second to the eosinophilic granulomatous polyangiopathy. We recommended this diagnosis according to the clinical criteria of Charles Strouser, according to the American College of Rheumatology, that we have four of the following: asthma with eosinophilia more than 10% of the total white blood cells, peripheral neuropathy, transient pulmonary infiltrate, paranasal, and the biopsy. We have three of them: asthma, eosinophilia, with peripheral neuropathy, transient pulmonary infiltrate, and we waiting for the renal biopsy. We have another leukotrienes receptor antagonist. We know that it plays a role in the pathogenesis of the Charles-Strauss, so we suggest that RPGN secondary to the Charles-Strauss, and beginning the treatment in the form of pulse steroid 1 gram for 3 days, following by the prednisolone 16 milligram per day, and additional pulse cyclophosphamide, and we started a therapeutic plasma exchange. As our case is ANCA negative vasculitis, according to that criteria, there is an ANCA negative and ANCA positive vasculitis. In the both ANCA, we have eosinophilia, chronic rhinosinusitis, or asthma. But the ANCA positive, we have glomerulonephritis, with peripheral neuropathy and burbra. For ANCA negative, present lung infiltration, cardiomyopathy, and the gastroenteritis. So the first renal biopsy with an ATIC1 and relieved only one glomeruli with feature of interstitial nephritis for rebiopsy. And we do the second biopsy in our department. And the result of the second biopsy showing that focal necrotizing glomerulonephritis with 60% of the crescent, compatible with the immune small vessel vasculitis, which improve our diagnosis as vasculitis. Additional features, this was focal global glomerulosclerosis 35% with mild interstitial fibrosis and tubular atrophy 15%. And we noticed that there is in the immunohistochemistry, there is no immunoglobulin or complement deposition in the biopsy. So we complete our treatment. And this is the diagnostic workup for the Charles-Strausers. We have an investigations we will perform to the old patient, including the routine laboratory examination with immunological workup, we infectious workup, we hematological, we imaging study the chest, pulmonary, ESNT, abdominal ultrasound to exclude the hepatosplenomegaly. And this is performed only in the selected patient with peripheral neuropathy or renal impairment, kidney biopsy, or GI endoscope, interventional endoscopy, ENT audiometry. And according to the evidence-based guideline for diagnosis and the management of the eosinophilic granulomatous with polyangiitis, which supported our diagnosis, that any patient we have expected in eosinophilic granulomatous with asthma and end organ involvement, and should be with suggestive clinical features and histology, and our histology suggested that is ANCA vasculitis. We have a biopsy recommended when possible. The ANCA are detectable only in 30 or 40% of the patients, so we suspected that there is an ANCA negative vasculitis. Cyclophosphamide is the treatment with pulse steroid and an alternative as rituximab. But unfortunately, our patient on the course of the march developed hemoptysis and oxygen saturation was 86 to 80% in the room air, and new CT chest showing pulmonary congestion or infiltration, and just the consultation saying that it's a bilateral fat wing appearance, which is a characteristic of the pulmonary hemorrhage. So the patient was transferred to the ICU for close monitoring for 1 week, where the general condition of saturation improved and hemoptysis with hemostatic intensification of the dialysis and therapeutic plasma exchange daily till the general condition improved. And after the complete of 14 sessions of the therapeutic plasma exchange, we send the antiglomerular basement membrane, which revealed that it is a positive with a high 40. So we diagnosed our patient as a Goodpatcher syndrome associated with ANCA-negative vasculitis on the serological and clinical base. Decision to resume the therapeutic plasma exchange until the antiglobulin basement membrane retained negative. Six sessions more over than 2 weeks were offered to her. Developed another attack of the hemoptysis despite of the therapeutic plasma exchange. We complete Indoxan half gram with the oral steroid. On 8/4/23, after 2 weeks, the titer was negative and she was again recommended after 1 week later and it was negative. After a prolonged hospital stay and the strict therapeutic protocol, the patient now is on maintenance hemodialysis and still anuric. Clinically, the patient is stable after 21 sessions of the therapeutic plasma exchange. We have 3 doses of cyclophosphamide 500 milligram, which was stopped due to the leukopenia, and 14 milligram of steroid. The antiglomerular basement membrane become negative. We have a pancytopenia, and the high resolution CT chest was free.
Recording
The-
in progress.
The patient was discharged on maintenance hemodialysis from the right internal jugular permanent cath. AV fistula creation was planned, and the advice of the pulmonologist that there is a no need of the Indoxan. The patient is now on steroid and on tapering for 6 months. The discharge medication steroid 40 milligram amlodipine, carvedilol, and calcium carbonate. So to summarize our case, it is a case of the pulmonary renal syndrome and its mimics. We have 3 parts. 90% of the pulmonary renal syndrome is an ANCA-associated vasculitis or antiglomerular basement membrane disease, or double positive ANCA-positive and antiglomerular basement membrane, which represent 10% of the patient. 10% have a low complement level, and this is طبعا اللي هم الانكا vasculitis والantiglomerular, it is a normal complement level. 10% with low complement level, including the systemic lupus, cryoglobulinemia, والmixed connective tissue, والantiphospholipid, والrheumatoid vasculitis, والscleroderma, والIgA vasculitis, والBEHCT, والinflammatory myositis. And mimics to the infection or disseminated infection or cancer and cardiac malignant hypertension and microangiopathic hemolytic anemia. And this is the Q2B22, the 5 takeaway for the clinician for the antiglomerular basement membrane, for the diagnosis, treatment, the length of the treatment, which is recommended by the plasma exchange until the antibody become negative. Refractory disease treated with the rituximab, and it is rare for refractory disease. Kidney transplantation, the patient with kidney failure due to the antiglomerular is shows to be postponed, and when the antiglomerular antibody become negative for 6 months. Take a home message. We suggested that it is a case of the Goodpatcher syndrome associated with ANCA-negative vasculitis, and we say that because of multiple organ involvement as the ANCA-associated vasculitis patient in related to the antiglomerular basement membrane patient. The antiglomerular, it is only restricted to the renal and the pulmonary, but our patient have another systemic affection. Renal involvement في الدبل اللي هو الانكا vasculitis and the antiglomerular basement membrane بيبقى more severe with a median serum level of more than 9.8, and about 2/3 required the dialysis at the diagnosis. Antiglomerular basement membrane disease in the histological hallmark is a crescent formation. We notice that in our biopsy, no crescent formation, there is an interstitial fibrosis and tubular atrophy, which is uncommon in the antiglomerular basement membrane. Surprising, our biopsy not showing linear deposition of IgG by the IR. And this can be explained that the ANCA vasculitis, the pathophysiology of the ANCA vasculitis occurred by the neutrophil activation by the ANCA could lead to the release of the oxidizing agents and reactive oxygen species, which is responsible for destructions of the glomerular basement membrane. Then this structure thereby expose the epitopes of the type 4 collagen, leading to the production of the antiglomerular basement membrane antibody. This patient might receive the same approach as those of the isolated antiglomerular basement membrane with addition of the combination of steroid and cyclophosphamide. And in the treatment of the ANCA vasculitis, we have a maintenance but in the antiglomerular basement membrane, in some cases after the relief, not need the maintenance. So in the double cases, we have to give a maintenance therapy. And thank you. Any question?
Thank you, Professor Heba, for this elegant presentation, actually. And we are waiting for the comment of our great Professor Sobh and my dear friend, Professor Yasser, and all the audience. Thank you so much.
Thank you.
Dr. Heba, thank you for this excellent presentation. The case is full of data. This rapidly progressive glomerulonephritis, starting by systemic manifestation from beginning, it looked as a case of vasculitis with a rapidly progressive glomerulonephritis. The pulmonary manifestation, I think, was pulmonary hemorrhage came late, but the beginning was that of rapidly progressive crescentic glomerulonephritis, and biopsy showed necrotizing eosinophilic granuloma. The point is that we know that the outcome depend on the creatinine at presentation. We started treatment when creatinine was 23. There was a lag of treatment of around 1 week when she came by creatinine, I think 1.8. Possibly if we started this aggressive treatment, the outcome possibly will be better than when we started 1 week later on. This is one point.
But unfortunately, my professor, she came to us with creatinine 23. She was in a private facility outside the house, unfortunately.
Yeah, I seen if we started when it was 1.8, possibly the outcome was will be better than this.
But you mean renal wise?
23, so there was, due to being outside the hospital and managed elsewhere, this was a cause of delay. So early initiation of treatment possibly is very critical. And she was unlucky. She came to your unit when she was 23. So 23, we expect that the outcome will be, as we see now, anuria and dialysis dependent.
Yes.
This is a good point. Besides, interesting in this case, she later on developed this pulmonary hemorrhage, and anti-GBM was positive in serology.
Yes.
But what about the immunofluorescence examination of the second kidney biopsy? Was it negative or was it positive? We expect it to be linear deposition. There was linear deposits. So, okay.
So, unfortunately, Professor Sobh, there was no linear deposit.
There was no.
Yeah.
But why there was no? Is there an explanation for this?
You can answer, please, Dr. Heba.
The explanation of this condition that the condition is started with ANCA positive vasculitis, and the development of antibody against the endothelium of the blood vessels, leading to the exposure of the basement membrane of the blood vessel, and the development of the antibody to the glomerular basement membrane, which affecting the kidney, and develop the antiglomerular basement membrane disease. So the patient develops later after the presentation of vasculitis with pulmonary hemorrhage attacking the basement membrane.
So you mean there was a two-wave of illness? Yes, the first wave was that of eosinophilic granulomatosis with polyangiitis. Then later on she developed this anti-GBM. But if you repeat biopsy, possibly you will find this anti-GBM.
It could be, yeah.
If you repeat biopsy. Yeah. And actually, there is an indication to redo biopsy to decide either to terminate this aggressive treatment and say she is in the stage, or you
Yes.
continue giving a level of immune suppression,
Maintenance.
hoping for
Immunosuppression.
a recovery, which could be partially or not. But it seemed anuria, a long time, need of dialysis this period, it seemed it will be irreversible.
Yes.
But
yes.
Yes.
for interest, possibly we may repeat the kidney biopsy if the kidney size allows this.
Okay.
Again, Dr. Heba, what about rituximab as induction, as maintenance in patient with this type of ANCA, whether negative or positive vasculitis? What is the role of rituximab? Can we start instead of endoxan as induction? Can we keep it as maintenance as well?
Some literatures beginning the rituximab as induction therapy in the ANCA-associated vasculitis when the rising creatinine presenting of RPGN and pulmonary hemorrhage, we can begin with the induction of the rituximab and other literatures saying that we begin the valsartan and endoxan and gives a chance and using the rituximab in the cases of the refractory case, which is not responding to the endoxan. The first choice is endoxan or cyclophosphamide. Then we started with rituximab in the cases of unresponsive or refractory cases.
Yeah. Okay. Yeah. Okay.
Yeah. We have two questions on the chat from Dr. Khaled Abu Zaid asking about expected duration of different renal diseases, especially in cases of RPGN to reach tubulointerstitial fibrosis.
Okay. Yeah, good question. You mean, for example, in a case like this, an acute illness occur, when fibrosis will occur? This is the question, huh?
It means in such acute case, when to expect that this case is an end stage.
Yeah, I see.
Expect the time from this aggressive course to reach end stage kidney disease.
There is a clinical and histological, I think.
Yes.
A case presenting like this with this very high creatinine and uric and dialysis dependent, and you started this aggressive treatment without recovery, with persistent anuria, need of dialysis for 2 weeks or 3 weeks, I expect the patient will not recover unless very little. I mean, she will show some urine, some decrease in serum creatinine, but I think at the end she will go into irreversible kidney damage. Yeah, so you have clinical expectation, high creatinine, failure or initial response, progression despite aggressive treatment. All these are bad omen. The time elapsed with no recovery, the less possibility of recovery of kidney function. So the initial presentation, initial response to this aggressive treatment will give us an idea, is the patient going to recover or not? To do biopsy, real biopsy, I think you give a good treatment, at least give a chance, let us say 4 weeks. If no response, repeat biopsy. And to continue aggressive treatment or not depend on the degree of interstitial fibrosis and tubular atrophy. So if after 4 weeks, still no recovery and fibrosis still start to show up and increasing, this will give you an idea. This will not be a good case, and possibly she will pass into end stage.
Let me
This
stress
is
again.
my opinion, yeah.
Let me stress again on your words, Professor Sobh, that 4 weeks are the usual period to reassess again our patient if there is response or not, and it's expected period for fibrosis to occur and to reach an end stage renal disease in such an aggressive course.
Yeah, I think so.
Okay. Another
Second
question from Dr.
the
Tamer.
start. Yes, from Dr. Tamer.
From the start, you did not have anti-GBM with the immune and serology. Asking Dr. Heba, did you have anti-GBM antibodies?
The presentation of our case in the first case not classic of the anti-glomerular basement membrane with pulmonary and renal hemorrhage, which is represented mainly by pulmonary hemorrhage and renal affection. So our thinking towards the ANCA, and then when the hemorrhage developed, to be thinking about the anti-glomerular basement membrane. But the rule to start with it, but unfortunately in Egypt we try to beginning with the most important because financial of the patient.
I have a question that is not that clear, and if anyone can clarify, or we can ask him to open the mic and illustrate his question from Yuga Tap to everyone. As per presentation, plasma exchange started when diagnosed as CCSS before pulmonary hemorrhage. What is the rationale? He's asking about starting plasma exchange without the presence of pulmonary hemorrhage. Also, the patient came with serum creatinine 23 if there is no pulmonary hemorrhage. Do you think that immunosuppressive course is an aggressive course? Serum creatinine 23?
If you allow me and Professor Sabha, I can answer her or him his question. We have no doubt that this starting with this aggressive immunosuppression is wrong. No, it is correct as per most, if not all, the literature. We should start the treatment for such patients on clinical data or stigmata you have, and don't wait for the biopsy or for the full-blown picture of this aggressive disease. We know that renal-wise was not promising from the start. I mean the patient, I mean the prognosis. But we started this based on that the patient has asthmatic attacks before the onset of this disease, plus she used this montelukast as a treatment. And in the meantime, the patient came with very aggressive course of renal deterioration, I mean downhill course, plus few symptoms, but later on we detected that she has hemoptysis. Could we blame ourselves at that moment if we didn't start with this aggressive treatment or not?
Dr. Said, I think this case should be managed not as a renal case only. Can die from extra-renal causes.
That is the issue. That's the issue.
And so even when she will be on maintenance hemodialysis, we have to follow the disease activity since she can die from other.
That is the issue.
So follow up by chest physician, looking for anti-GBM, looking for repeated radiology. Kidney-wise, I think the kidney will not recover mostly. And at the time, possibly we'll do rebiopsy to say the kidney is okay, she will not recover, she will be on permanent dialysis. And when we gave treatment at the beginning with this creatinine of 23, we know possibility of recovery of kidney function is poor, but the patient will die from this pulmonary hemorrhage. So even the kidney will not recover, but I have to be aggressive in my treatment. There is a point that immunofluorescence was done with the early biopsy, the second biopsy.
That's what I told you.
And it was negative regarding immunofluorescence. So positively, later on, anti-GBM appeared. So anti-GBM came later, it seems so. It came in a second wave of the disease. And we know when there is a combined lesion, anti-GBM and ANCA, usually the prognosis is bad.
Totally agree.
Yeah, but also remember, Professor Shahad,
we need aggressive course is indicated from the start, and as you said, Professor Sobhat, is only 4 weeks. for the kidney to be lost. So I think we should be aggressive from the start. Another question?
Actually, if I meet this case, even before biopsy, when she came with this vasculitis and came with this high creatinine and 1.8, actually she lost 60% of her kidney function. And proteinuria and systemic vasculitis, I will give pulse steroid, 1 shot of endoxan, then I will go for biopsy. So I will be aggressive from the start.
Okay. Another question and comment, and we will go to the second case. Another question from Dr. Haitham Radi: if no pulmonary hemorrhage in TPE useful in ANCA negative as it was in ANCA positive vasculitis, do you monitor the titer of ANCA? I don't think we they don't mention. They did not mention that they monitored ANCA titer.
But the way she is ANCA negative all the time.
I don't. مش عارف ليه بيقول. Don't think.
Yeah, ANCA. She is
another
ANCA
question.
negative.
If she was ANCA positive from the start.
And it is ANCA negative all time, not ANCA.
But maybe it's asking as a general statement. Maybe Professor Subhi can answer him.
Yeah, of course. If ANCA positive, this ANCA positive and anti-GBM positivity, I have to follow them up to see how they are going to. Since we know ANCA positive can affect extra-renal tissues, and NGBM can affect also the lung. So I can keep giving immunosuppressive drugs despite the loss of kidney function. So far, I have high level of this immune reactant. And I will tailor my immune suppressive treatment according to the level. Yes, I will do this.
Okay. Last comment from Dr. Khaled Abu Zaid that the diagnosis of anti-GPM disease requires demonstration of anti-GPM antibodies either in serum or kidney biopsy. Kidney biopsy should be performed unless there is contraindication because the accuracy of serological assay is variable. Of course, we know all that the accuracy of a serological assay is variable in between centers and in between countries.
Yeah, but I can add one statement if you allow me, Professor Yasser. As Professor Khaled said, there is one rare form of anti-GBM, which is already rare anti-GBM. It's 1 per million instance, by the way, the anti-GBM disease or not Bashar. Another rare subform from this anti-GBM is called atypical form of anti-GBM. That means seronegative. That means there is no antibody in the serum and proved by only the biopsy. So biopsy is mandatory, as Professor Khaled said.
Thank you, Professor.
Possibly the titer is low and the antibody are absorbed by the kidney.
Yes.
Thank you, Professor Subh and Professor Saeed, for your illustrations and comments. Let we move to the second case. For the second case, Professor Saeed, please.
Bismillah ar-Rahman ar-Rahim. Thank you, Professor Yasser. Thank you, Professor Subh. It is a great honor also to introduce my daughter, Dr. Safwa Osman Toulan, lecturer of internal medicine and nephrology, Forum-Menoufia University Hospital. She will introduce a second case today, and we are listening to Dr. Safwa, please.
Bismillah, alhamdulillah, wassalatu wassalamu ala rasulillah. I'd like to present my deep thanks to Dr. Saeed Khamis, who permitted me to be with pillars of nephrology in Egypt. Great honor to be with Dr. Muhammad Subh, who is no nephrologist in Egypt, didn't learn from him. I'm so happy to be with you, Dr. Yasser. I'm so happy to be with my colleagues, Dr. Heba and Dr. Muhammad. We'll talk today about eye-kidney link. It will be an interesting case, I think. Our patient, 19 years old, female, end-stage renal disease patient from Forum-Menoufia. She is currently an undergraduate student in the last year of Faculty of Media, single blind with no special habits of medical importance. She is hypertensive on 3 antihypertensive medication. End-stage renal on regular hemodialysis for the last 10 years at Ain Shams University Hospitals. Recently, she was transferred to our dialysis unit Forum-Menoufia University Hospital. She spent 1 year in the pediatric hemodialysis unit at our hospital, then transferred to our hemodialysis unit without any clear documents pertaining to the diagnosis of her original kidney disease or air syndrome she has. We tried to contact her treating pediatrician to retrieve any data about her earlier medical history, but we failed to get any helpful information. Then, what was the scenario? The condition of our index case started when she was 2 years old, where her mother noticed vision problems and strange eye movements side to side and rapid horizontal nystagmus, plus diminution of her daughter's vision. She sought medical advice for her little daughter at that time. The young girl, 2 years old, underwent exhaustive medical investigation. The results of this investigation were as follows: electroretinogram, subnormal functional state and response of outermost layer ganglion cells and innermost layers of retina, and visual evoked response with left eye affected more. IQ assessment of the patient was normal to age with no other signs of any organ affection. The results of biochemical hematological lab parameters were within normal limits for her age. Over the time, the patient experienced progressive diminution of vision, especially in the dark. At 7 years old, another electroretinogram was re-performed for the patient. It showed bilateral severe tubular contraction of visual field, retinal dysfunction, macular dysfunction, optic nerve dysfunction, and impaired retinocortical transmission affecting left eye more. A picture suggestive of inherited retinal degeneration consistent with primary pigmentary retinopathy. And this is the electroretinogram. At 7 years, other symptoms developed: polyuria, nocturia, excessive thirst. She was not diabetic or have diabetes insipidus. Eye knuckling, as we see in the picture, no history of hematuria or facial puffiness. Lab and other workup at 7 years: elevated serum creatinine 5 mg per deciliter as per mother. Renal workup including urine analysis, abdominal ultrasound, and renal biopsy. No available report were performed. Her height weight was normal compared to her classmates. She was of average mood and intelligence. Report of abdominopelvic ultrasound at that time, highly suggestive of nephronophthisis, bilateral multiple tiny renal cysts. The previous one was completely normal. Progressive deterioration in kidney function. The patient was labeled as an end-stage renal at 8 years old. Became on regular dialysis in Ain Shams pediatric dialysis unit. Recently, the patient was transferred to our dialysis unit. Assessment of the patient upon transfer to our unit. At time of transfer, patient could only perceive light. Fundus examination, retinitis pigmentosa affecting both eyes. Bilateral rapid horizontal nystagmus, no other remarkable findings. Abdominopelvic ultrasound showed bilateral shrinking small kidneys. Odometry showed normal study. Echocardiography, mild LVH, and mild degree of diastolic dysfunction. X-ray examination of femur and hand wounds to exclude findings suggestive of coronary syndrome was performed with no features suggestive for this syndrome. He has secondary hyperparathyroidism provoked by lab neck ultrasound STEMBI scan planned for parathyroidectomy. This is the fundus, as this is the renal ultrasound. This is the bone to exclude coronary syndrome. Odometry and echocardiography. What about the family history of our patient? Our patient is 6 born out of 4 fecal consanguineous marriage. There was a positive family history of the same condition because her older sister, she developed the same constellation of symptoms with loss of vision and developing end-stage renal disease at 8 years. But she died shortly after being on a maintenance hemodialysis for 3 months only. Then what is the diagnosis? We propose the diagnosis one of the differential diagnosis of hereditary renal-retinal syndromes. After comprehensively reviewing our patient history, clinical presentation, as well as the readily available investigation, we can highly suggest that her overall medical scenario is mostly consistent with the diagnosis of senior Loken syndrome. The final diagnosis of senior Loken syndrome should be confirmed using genetic testing, but this is postponed for financial problems. Signs of senior Loken syndrome: juvenile nephrophysis with liver amaurosis, renal dysplasia and retinal aplasia, renal dysplasia, blindness, hereditary, renal retinal dysplasia, renal retinal syndrome, Loken senior syndrome, senior Loken syndrome. Senior Loken syndrome is a genetic defect. The characterization of clinical situation results from the protein defect. The protein defect results in a specific clinical picture for each defective protein for each defective gene, resulting in ciliopathy. General feature of senior Loken syndrome is a rare autosomal recessive disease with a prevalence of 1 per million, present worldwide with no special predominance. 10% of nephrophysis cases is senior Loken syndrome. Retinopathy may progress as liver congenital amaurosis, retinitis pigmentosa, or sector retinitis pigmentosa. Onset of photophobia, nystagmus, hyperopia can occur in the first few years. Experience nephrophysis characterized by cystic kidney disease, medullary cystic, which progresses to end-stage renal disease. Hypertension is common. As we see, the summarization of clinical assessment of senior Loken syndrome case. As we see, 9 genetic defects associated with nephrophysis, with different clinical presentation upon the defective gene resulting in a defective protein, as we see nephrophysis 1, 2, 3, 4, 5, 6, 7, 8, 9, resulting in a clinical presentation different from each other upon the defective gene and defective protein. Liver may be involved, neurological system may be involved, as we see in different syndromes. Syndromes associated with nephrophysis and the silent feature. A lot of syndromes are associated with nephrophysis, not only senior Loken syndrome, serial Loken syndrome, Sardino-Manzarri syndrome, Joubert syndrome, Koch syndrome, Arima syndrome, Alstrom, John syndrome, Michael-Cooper syndrome. A lot of syndromes linking the eye, kidney, the polyuria, polydipsia, and vertigo. The earliest clinical signs in senior
It seems to be some technical problem, Professor Yasser.
Okay. Diagnosis of senior looking by genetic testing and the clinical examination. A complete renal and ophthalmologic evaluation should be performed, as well as the recommendation of hepatic and neurological exam. Genetic diagnosis will require neuropsysis 1 gene to detect the deletion in that gene. Treatment of senior local nephrosis. The child weight, height, kidney function, urinary concentration, and blood pressure should be monitored. An early diagnosis of nephronophthisis can be managed and delay the progression of kidney failure. However, once in the stage renal disease develops, the patient there is no treatment to prevent the progression of vision loss. To sum up, 19-year-old girl, 6 born out of 4th-degree consanguineous marriage, known as end-stage renal disease patient for the last 11 years and recently transferred to our hemodialysis center at Menoufia University Hospital. The condition started 17 years ago with rapid horizontal nystagmus and diminution of vision. Over the time, she developed progressive vision deterioration, especially in the dark. Electroretinogram performed at age 7 showed a picture suggestive of inherited retinal degeneration consistent with primary pigmentary retinopathy. At age 7, she developed polyuria, nectoria, excessive thirst, and eye knuckling. At time of transfer, she could only perceive light. There was no history of hematuria or facial puffness, no clinical physical abnormalities identified. Lab workup showed elevated serum creatinine. Her height and weight was normal compared to her classmates. She was average of mood and intelligence. Extensive renal workup, including urine analysis, abdominal ultrasound, nephronophthisis picture. At the time, renal biopsy was performed, but no available data at time of transfer. Over the next year, kidney function deteriorated with development of uremic symptom, and she was diagnosed an end-stage renal disease on regular hemodialysis. There was a positive family history as her elder sister developed at the same condition, loss of vision, developing end-stage renal disease at age of 8, but she died 3 months later after initiation of hemodialysis. After comprehensively reviewing our patient history, clinical presentation, as well as the readily available investigation, we can highly suggest that her overall medical scenario is mostly consistent with diagnosis of senior local syndrome. Taking home message. Many inherited renal diseases have retinal features that are helpful diagnostically. These include glaucoma, drosel atrophy, and pigmentation, retinitis pigmentosa, hamartoma, vascular anomalies, and crystals. Retinal abnormalities occur because the kidney and retina share developmental pathways and structural features, including basement membrane, collagen 4, promoter composition, and their vascularity, and because both the kidney and retina are functionally dependent on ciliated cells. Diagnosis of inherited renal disease is important because the risks of further renal and systemic complications, the implication of other family members, the predictability of the clinical course, and the possibility of treatment. Furthermore, retinal abnormalities may help explain the pathogenesis of the renal disease and can sometimes be used to monitor its course. Thank you so much.
Shukran, Dr. Safwa. Thank you so much, Dr. Safwa, for this elegant presentation. And we are anxiously waiting for the discussion by our great Professor Sabha and my dear Professor Dr. Yasser Abdelhamid and all the audience. Thank you so much.
Thank you, Dr. Said.
Thank you for this case, strange case, very unlucky girl. What came across my mind, is she eligible for transplantation? At least to relieve him from one agony of the dialysis, and we just leave the blindness. And if we go for transplantation, what is the effect of the drugs, of the immunosuppressive drugs on her ciliopathy and her whatever eye complication she has? She lost her eyes forever, it seems. So is there a place for transplantation in this girl?
Okay, our great Professor Subh is there, or may I answer Professor Yasser if he is not there? Professor Yasser?
And if we go for transplantation, of course, I will never have a related living donor. It has to be an unrelated donor. She has a very strong family history of this condition.
Yeah, it is, and as I remember, it is autosomal recessive, Professor Dawla.
Yes,
Yes.
that's right.
So if yes, Safwa,
Yes, yes.
autosomal
The
recessive, yes.
percentage, 25% in every pregnancy.
Yeah. So if we do genetic test for all the family, if they are willing to donate, maybe we can detect 1 or 2 or 3 can be eligible for donation. But apart from this, transplantation can be a solution for this issue, for this disease. Yes, it can be. And even it can be from the relative, but after genetic testing for the donor. And even regarding the genetic testing for the patient herself, we are knocking many doors to afford us this genetic testing. And fortunately, maybe within 1 or 2 weeks, it can be performed after we contacted one of the great professor in Cairo University, pediatric nephrologist. She promised us to do it freely for her. But till this issue will be solved, I think the transplantation, as per literature, is a good solution for such a patient if affordable and feasible.
The question here, is it going to be a recurrent condition if she's transplanted?
As I read, as to best of my knowledge, no, it's not recurrent. It is apart from what's called the nephronophthisis, or as a big title, what's called the ciliopathies, as you know. So
Yeah.
to my knowledge, it is not recurrent.
Okay. So there's a chance for her here.
Yeah.
Okay, no more questions, Professor Saeed.
Safwa mentioned at one of the stages that the condition could have been prevented somehow in one of the slides, and I don't know, I did not understand this point. Said it could have been, at least the kidney wise, could have been prevented.
Yes.
Yes.
What did you mean?
We can deteriorate the progression of CKD.
You can hold, you hold
yes.
the progression.
You can control blood pressure at the condition is characterized by severe hypertension from the start. So if you control the blood pressure, you will control this item. If you avoid nephrotoxic drugs, you will control this item. Good hydration for the child from the start, you will avoid this deterioration. So you can delay the progression of CKD by this way, by controlling the variabilities that affect the CKD progression.
All right.
But your eye will be on the kidney from the start. Your eye will be on the kidney from the start. Before hypertension starts.
Okay.
As the vision loss start early than kidney affection. So if you find or detect this patient, you will control the kidney from the start, even before the kidney condition will start to appear.
So, Dr. Safwa, the concern of Professor Dawlat is regarding the wording to prevent it. No, can be changed into delay the progression, but prevent it is a striking word, you know, huh?
Yes.
It's a ciliopathy, so it's happening anyway.
Yeah. It is a relentless course.
There is papers about B2 receptor blocker and managing the ciliopathies. New papers and the new work will affect the senior local syndrome also.
Hoping so.
Yes. B2 receptor blockers.
Okay.
Professor Yasser?
Yes, Professor Saeed, we can move to the third case.
Thank you, Professor Yasser. The third and the last case will be presented by my son, Dr. Muhammad Samir. He is an assistant lecturer of internal medicine and nephrology. He is one of the, like Professor Heba and Dr. Safa, one of the promising persons in the Menoufia University Hospital renal unit. And inshallah, we shall listen from him good talk about this issue he will project. Please, Dr. Muhammad.
Thank you, Dr. Saeed. First of all, I'd like to show all meanings of honor to my great professors, Professor Muhammad Sobh, Professor Yasser Abdel Hamid, Professor Saeed Khamis, my dear seniors, and all the generous audience. Relatively new, relatively old. What is new, what is old? Let's start. Our patient, a 10-year-old girl with a background of family conflict, alleging suicidal attempt. She ingested 20 tablets of 300 milligram of cyphylline Kebron TSR. So she ingested about 6,000 milligram. Our patient is of 60 kilograms, so she has ingested 100 milligram per kg. It's a lethal dose of cyphylline. She presented to ER with vomiting, palpitations, heart rate of 130 beats per minute, regular sinus rhythm ECG, blood pressure hypertensive, 90/60, irritable, initial laboratory investigations, and cyphylline blood level was drawn at ER, and our patient was admitted to toxicology department. At toxicology department, our patient started administration of activated charcoal vasogastric tube and ondansetron for vomiting. Her labs revealed severe hypokalemia, 2.7 milliequivalent per liter, severe metabolic acidosis with bicarb of 13 millimole per liter, normal random blood sugars. For 3 hours later, she started attacks of repeated fits that necessitated transfer to ICU. In the ICU, she was severely agitated, distressed, with heart rate 170 beats per minute and ECG revealing supraventricular tachycardia, hypotension, shocked with blood pressure of 80/40, severe respiratory distress with respiratory rate of 40 breaths per minute. She was intubated, ventilated, sedated using dormicum with correction of acidosis on noradrenaline, amiodarone for arrhythmia, and levetiracetam for fits. Her lab result is showing severe leukocytosis, severe hypokalemia, 2.7 milligram per milliequivalent per liter, and severe hypophosphatemia, 0.7 milligram per deciliter, and elevated troponin and CPK. So in brief, regarding cyphylline intoxication affecting many systems of CNS, GIT, CVS, respiratory, and metabolic dearrangements, our patient nearly had all the drawbacks of cyphylline intoxication, with a great attention that should be paid to seizures, hypotension, and fatal arrhythmias, and the metabolic consequences. According to our toxicology consultant's point of view, our patient ingested a lethal dose of cyphylline, and all previous cases that they have encountered with such severity had a fatality rate of almost 100%. It was a hopeless case. Besides, no available cyphylline level was available at this point. So at this point, should we consider extracorporeal treatment for this patient, and why? And if yes, what kind of modality and why? What is the prescription order, and when should we cessate? Considering extracorporeal treatment for patients with poisoning, or in other words, poisons amenable to extracorporeal treatment, poison should have a low molecular weight. Higher molecular weights can have other extracorporeal treatments rather than hemodialysis, like hemodiafiltration, hemoperfusion, therapeutic plasma exchange. In most poisons, the molecular weight is below 2,000 Daltons, and in case of cyphylline, it's 180 Daltons, sufficient for dialysis with high flux dialyzers. Poisons should also have a small volume of distribution to guarantee that the major moiety of poison is in the plasma, not as a depot in tissues. So it could be amenable with extracorporeal treatment, and in case of cyphylline, it has a low volume of distribution of 0.5 liter per kg. Persons should also have low protein binding. If they have higher protein binding, we can consider this problem using hemoperfusion or therapeutic plasma exchange. And in case of syphilis, it's 40 to 60% only, and low endogenous clearance. So, according to this, syphilis is amenable to extracorporeal treatment using multiple modalities, including hemodialysis, hemodifiltration, prolonged intermittent kidney replacement therapy, continuous renal replacement therapy, peritoneal dialysis, hemoperfusion, and therapeutic plasma exchange. So, which modality should we select? In terms of molecular weight, syphilis has a low molecular weight, making hemodifiltration and hemoperfusion and therapeutic plasma exchange are likely options, but are not the preferred ones. Also, all the literature available was suggesting hemoperfusion as having the most efficient clearance rate. But hemodialysis now is a cheap, quick, and efficient form for extracorporeal treatment of the poison. And considering prolonged intermittent kidney replacement therapy, efficiency could be increased due to increased QP and time, but on the expense of electrolyte disturbances that could occur like hypophosphatemia and hypokalemia we should pay special consideration in cases like syphilis toxicity presenting from the start to severe hypokalemia and hypophosphatemia. CRRT is a good option in hemodynamically unstable patients, but it has efficiency of 50% of that achieved with hemodialysis. Peritoneal dialysis is a good option in units and in low resource settings, but with efficiency of only 10% of hemodialysis. So regarding this data and revision of literature, performing extracorporeal treatment when indicated is better than no treatment. On the slide of another poison of methanol, comparing different modalities of extracorporeal treatment that could make the level down to the safe zone, we could see that using hemodialysis can reach the safe zone within only 9 hours compared to about 70 hours in peritoneal dialysis compared to about 200 hours in no extracorporeal treatment. It shows how much there is a comparability between different forms of extracorporeal treatment with a great clearance rate for hemodialysis. At this slide, the review of literature on different modalities of extracorporeal treatments in case of syphilis intoxication, we could see that the clearance rate for syphilis clearance in charcoal hemoperfusion is over 100 milli per minute compared to 82 milli per minute in hemodialysis. But we should notice that these findings are returning to 1997, and this shows the mean clearance collected from data through literature starting from 1970s, where hemodialysis was with a low efficiency and low clearance using obsolete modalities for our time now, achieving a clearance of only 30 milli per minute. So putting this data together, we could consider that hemodialysis and especially prolonged intermittent kidney replacement therapy is an effective modality for syphilis intoxication. So our decision was to insert a temporary hemodialysis central venous catheter and starting prolonged intermittent kidney replacement therapy. On the first day of admission, we started the first session with a duration of 6 hours and using a dialyzer of high surface area 2.2, the largest surface area available at our center, high flux with QP of 300 milli per minute and the QD of 500 milli per minute on continuous ECG blood pressure, oxygen temperature, and heart rate monitoring, and using dialysate concentrates that could match our patient with continuous monitoring hourly of random blood sugar, BPG, and potassium, and IV potassium infusion rate of 20 to 30 millimole per hour, adjusted according to lab results. After completing our first hemodialysis session, our patient was still miserable, intubated, ventilated, sedated, blood pressure maintained on norepinephrine. The only improvement was that her cardiac rhythm was sinus. So after 12 hours only, and on second day, we started a second hemodialysis sessions with labs showing hypokalemia improved with correction and replacement of 3.3 millimole per liter, but hypophosphatemia is still present. One, caused lack of IV correction due to lack of the resources available. And CPK is shouting up at about 10,000. So we started a second session of more prolonged course, 8 hours, using the same data, but with less frequent potassium monitoring and a lower rate of IV potassium infusion at 10 millimole per hour, adjusted according to follow-up lab results. After completing the second hemodialysis session, it was likely a miracle when we noticed our patient became vitally stable, fully conscious, extubated, and gradually she was off vasopressor medications. We exerted many efforts to correct hypophosphatemia orally until we eventually could find sodium phosphate IV forms to correct hypophosphatemia to counteract rhabdomyolysis secondary to low phosphorus, low potassium, and the previous convulsions. So on the third day of admission, our patient now having a potassium level of 4, phosphorus level of 2.8, and CPK is going down of 2,000. We started a third hemodialysis session that we considered it as a prophylactic one. We were afraid of a rebound rise in thiophyllin level. We started a session with the duration of 8 hours using the same previous parameters. And on the fourth day of admission, our patient was nearly completely normal with serum phosphorus of 4, serum potassium 3.8, fully conscious, cooperative, and she was discharged from ICU to toxicology department. Her serum thiophyllin levels came back and showed that before initiating hemodialysis was 96 microgram per milliliter, and after the third hemodialysis session, it was 8.4 microgram per milliliter. On fifth day of admission, our patient was discharged with any lab or clinical sequelae. Since her improvement, we consulted the psychiatrist and social worker for following up our patient. 2 weeks later, she attended to our nephrology outpatient clinic for follow-up, and she was showing clinical and laboratory data that are normal. We consulted their family to address and discuss the social issues she faced in the presence of the social worker, and she was referred to follow up at the psychiatric clinic. So what is prolonged intermittent kidney replacement therapy? It's a hybrid form of kidney replacement therapy that is intermediate between standard hemodialysis that is up to 4 hours in duration and continuous renal replacement therapy that is up to 24 hours in duration. Also, the term was introduced in late 1990s, but its use came to the forefront during the COVID-19 pandemic due to low resources that enabled us to face all the critically ill patients with CRRT. So at this slide, we show that prolonged intermittent kidney replacement therapy is intermediate between intermittent hemodialysis and continuous kidney replacement therapy in terms of blood flow rate, dialysate flow rate, ultrafiltration duration, and frequency. And of the major limitations of that modality is the metabolic arrangement is in the form of hypophosphatemia and hypokalemia that we should pay consideration to. The extra work group or the extracorporeal treatment on poisoning work group is a group that can provide us with summaries for poisoning indications, when to initiate and when to cessate. The recommendations are not definitive due to low quality, but the available data are the best guidance to date. In cases of thiophyllin toxicity, the extra work group suggests initiation of hemodialysis or extracorporeal treatment if cyphilin blood level over 100 milligram per liter, seizures present, life-threatening arrhythmias, shock present, or clinical deterioration despite optimal therapy. Probably almost all these findings were present in our case. They recommend the cessation of extracorporeal treatment. No, they suggest using intermittent hemodialysis as the preferred recommended extracorporeal treatment, and alternatives like hemoperfusion, CRRT, and exchange transfusion could be used. They recommend that multi-dose activated charcoal should be continued during extracorporeal treatment because there is a rebound in the form of increased absorption, especially with extended release forms. So MDAC should be continued despite initiating of extracorporeal treatment to prevent that rebound. To the best of our knowledge and after exhaustive review of literature, we could admit that this is the first reported case of cyphilin intoxication that was treated with prolonged intermittent kidney replacement therapy, and this therapy was highly efficient at our patients. The extracorporeal group suggested cessation of extracorporeal treatment when clinical improvement is apparent or cyphilin level below 15. So we think that our third hemodialysis session was of great importance to our patient. On the other side, it was on expense of her electrolyte balance regarding potassium and phosphorus. As regarding the extracorporeal group, after clinical improvement only, we can hold the extracorporeal treatments, especially due to the low volume of distribution of cyphilin, so the fear of rebound should only be considered with reabsorption issues that take almost about 6 to 8 hours in cases of cyphilin, and we started the third session after about 48 hours. So prolonged intermittent kidney replacement therapy is a relatively new modality that was effective in treatment of cyphilin intoxication, relatively old poisoning. Importance of multidisciplinary team management. We didn't work on this case alone. Our colleagues from ICU, toxicology department, even the nursing, all made their utmost efforts for the case. Prolonged intermittent kidney replacement therapy can be used effectively in poison management. Clinical picture can guide the decision to extracorporeal treatment in cases of cyphilin intoxication, in case of absence of cyphilin plasma level. So the patient is indicated if there is seizures, hypotension, severe shock, go ahead, don't hesitate, don't wait for the cyphilin blood level. And also, when we consider the session of extracorporeal treatment, clinical picture can be used as a guide instead of cyphilin blood level. Prophylactic hemodialysis after clinical improvement is not recommended due to the low volume of distribution. We should choose a crucial role of nephrologists in management of poisoning and intoxication. Thank you.
Thank you, Dr. Muhammad, for this extremely elegant presentation. Actually, you were marvelous in your talk, and as usual. And thank you so much. Now the floor is for Professor Yasser to organize this discussion. Professor Yasser.
I want to ask a question about prolonged intermittent kidney replacement therapy. Dr. Muhammad, are you following me?
The sound, just you can raise the voice شوية, Dr. Yasser, please.
Yes, I am asking about prolonged intermittent kidney replacement therapy you used. Can you tell us about the parameters of QD and QP in this prolonged intermittent treatment?
Okay, the QP was 300 milli per minute, and the QD was 500 milli per minute.
500 milli per minute?
Regarding QD and the QB of 300 milli per minute.
did you use a lower QD means sled low
No,
efficiency,
no, it
or
wasn't
you
a
used
sled. No, no. No,
you are in between,
we
you are in
tried to
between,
reach.
you are using in between QD, not that high and not that low.
We tried to reach the most efficient clearance rate for our patients. So we used the highest QD available and the highest QB. The difference between QD of 500 and 800, according to literature, isn't of great importance in improving efficiency of dialysis. So we used the QD of 500 milli per minute. And regarding QD, we used 300 milli per minute. I read that for a temporary hemodialysis catheter, I think is a good one.
Yes, yes, I totally agree with you. But I was asking if you used the sled session in any of your stages.
No, we weren't afraid at all of this equilibrium or things like that to start with a low efficient dialysis session and then upgrade our session. And this is the goal of our presentation to highlight how high efficient dialysis in cases of poisoning is from the start could be addressed.
السؤال يا دكتور ياسر، هي ضغطها يستحمل هيمودايناميكلي ستيبل انها تقدر تستحمل البريشر ده؟ يعني هي البلاد بريشر
we followed blood pressure and we were ready to adjust according to the patient case. On noradrenaline, she was stable all over the session, so why should we go down?
I think this patient will have يعني intermittent hypotension every يعني hour or more than يعني drop في البلاد بريشر او الهيمودايناميك ستاتس بتاعتها هتبقى unstable.
She was under continuous monitoring of blood pressure all over the session.
Okay.
And all the session passed smoothly, huh?
Yeah.
مساء الخير يا دكتور سعيد ودكتور ياسر.
دكتوره منال، ازي حضرتك يا فندم؟ الله يخليك، منورانا.
على البرزنتيشنز يعني، والدكتوره هبه والدكتور صفوه والدكتور محمد، بصراحه التقديم رائع جدا والحالات جميله جدا يعني. بس البيشنت الاخرانيه دي اللي هي كوميت سويسايد، يعني اي ثينك سويسايدال الانسيدنس اوف سويسايدال اتاكس among اللي هو منوفيا يونيفرستي منوفيا جفرمنت از فيري هاي. why I don't know, especially at the time of ثانويه يعني نتيجه الثانويه والحاجات دي هم دايما بينتحروا غرقا يعني. مش عارفه دي عشان يمكن تمريض او في مدرسه تمريض، فهي بقى خدت ادويه السيوفيل.
We don't have statistics, Professor Manal.
Yeah, we don't have statistics, but actually this girl, she is in the second year of faculty of nursing, and in the meantime she has a social problem, is a big social issue with her family or conflict. So it is away a little bit from the exam and so, but anyway, maybe this observation should be studied, but we have no
She needs psychological support. She needs a psychological
actually
support.
we consulted the psychiatrician from the beginning, and in the meantime we referred her to the psychiatric what's called a clinic to be followed up there, and we counsel her family, by the way, with the social worker to discuss all the aspects of her social problem. Otherwise, unfortunately, it can be repeated again, this suicidal tendency.
Yes, great effort, Professor Saeed and your team.
Thank you for this, for your attendance, Professor Manal, and your sharing with us.
Professor Dawla, please.
Yes, I have a comment here and a question. The problem with theophylline toxicity is hypophosphatemia, all right? And she is having daily dialysis and sometimes 8 hours. This itself is a treatment of hyperphosphatemia in the chronic renal failure patients.
Right.
So this will add a further problem for you to replace the phosphates. What we used to do is when I have a case of hyperphosphatemia, I dialyze daily. but I do not go over 4 hours, but because after 4 hours, the phosphate starts to rise due to mobilization from the bone.
Yeah.
So this could be a good privilege for you when you give her 8-hour dialysis. The other point is just to keep in mind that daily dialysis will wash the phosphate out. So you need to replace more aggressively the phosphate. And then what is the mechanism of hypophosphatemia in the theophylline toxicity? Why do they become hypophosphatemic?
I will, if Dr. Muhammad allow me, I will answer the first part of the question, and I can answer the second part if he doesn't mind.
Okay.
Regarding the first part, the patient from the beginning, she has a hypophosphatemia, hypokalemia, and
Yes.
in the meantime, she has a history of convulsions also. So we should have a high index of suspicion that she has associated rhabdomyolysis. So we checked the CBK and it was very high also. So we give her liberal fluid in the meantime. Let us go back to the hypophosphatemia. It's as a risk benefit ratio. We calculated this either to leave her to die from the syophyllin, or we should dialyze her to get rid of this syophyllin toxicity.
Right.
And in the meantime, keeping closely eye on the phosphate level and the potassium level and try to correct them as much as we can. We know that this aggressive dialysis could deteriorate the or added complexity to the already perplexing issue, this hypophosphatemia, hypokalemia, but we tried to correct meanwhile these two electrolyte disturbance while we are dialyzing here aggressively to get rid of this syophyllin, which is highly fatal if we leave it without aggressive therapy.
No, I didn't have a question for this. I just wanted to say that it adds to the problem of the hypophosphatemia. So
yeah,
you have to
challenging a problem. Yeah, challenging.
You have to be very alert.
Yeah,
Yes.
yeah.
But if you go beyond 4 hours, the phosphate comes from the bone. It becomes to the level starts to increase because it is taken from the bone. But
Right,
then
you are. Yeah, right.
that's the concept we learned, Yani.
Yes, you are right. Yeah.
About the mechanism, I'm not sure why theophylline produces hypophosphatemia. I don't know.
You don't know, Muhammad?
Actually, I searched every piece of literature regarding the pathophysiologic mechanisms of metabolic acidosis, hypokalemia, and hypophosphatemia. We have obvious mechanisms for hypokalemia and metabolic acidosis, but for hypophosphatemia, nobody mentioned the exact mechanism, but in acute setting of hypophosphatemia, we could consider either one of two, either mobilization into cells or increased renal excretion. And I think mobilization is more likely, but no exact mechanism is clear throughout exhaustive revision of literature.
I think one of our colleagues answered this also. Okay, Muhammad, but one of our colleagues answered this on the chat. Maybe Professor Yasser can read to Professor Dawlat.
Intracellular shifting, Khalid Abu Zaid said that intracellular shifting like potassium. This may be the mechanism related to phosphate depletion.
And Dr. Ibrahim also answered.
And Dr. Ibrahim Omar answered, I think no, it's a question. Why albumin dialysis was not tried to maximize thiophyllin clearance?
As we mentioned, the protein binding of thiophyllin is only 40%. It's a low percentage. It won't add a more clearance rate as absorption to albumin. So it's not recommended through the guidelines available, and we didn't pay attention to it really.
Especially it is expensive, and in the meantime, it will not recommend. It is not recommended, as you said.
Another question, yes. Another question asking about using phosphate enema to increase phosphorus. What about using phosphate enema to increase phosphorus?
This, but we didn't go for it. We considered high doses of 1-alpha skimmed milk, enemas, phosphorus. We searched for everything, but thanks God, we could eventually, within 2 days, make glyphosate available. So we didn't use these matters.
May I
Yes,
will answer also add to
he
this
speaks
answer,
about-
Professor Yasser and Dr. Muhammad. Using phosphate enema, if you remember, for colonic preparation for colonoscopy, it has a very bad sequelae also. It can lead to acute nephrocalcinosis, plus it can lead to AKI and eventually can lead to CKD even. So nowadays, even they don't use this phosphate enema for colonic preparation for endoscopy. And in the meantime, we were afraid to add a problem to the already existing problem. So we didn't use this phosphate enema.
Thank you, Professor Said, for your illustration. He speaks about that I think it is some case reports about a problem similar to your problem in not finding phosphate preparations, and they used phosphate enema. But
it could be a solution. I cannot deny it. Yes, it is a good suggestion. We discussed all these solutions. Really, he has the right to propose this solution, but fortunately, we could get this IV form as soon as possible at that time.
As you mentioned, your suggestion, Professor Said, let me ask you, why you jumped to the using prolonged intermittent hemodialysis? Why not you started with usual hemodialysis, especially in the face of electrolyte problems you faced? There is dangerous of more and more severe hypophosphatemia, more and more severe hypokalemia, and etc. etc. I think you're sure about the results that there will be a big difference in the results between using usual duration of hemodialysis and prolonged durations of hemodialysis, usual hemodialysis?
Right, you are. I have some, and maybe Dr. Muhammad add to this. I will tell you now. Number
yes,
one,
about your negotiations about this.
Yes, it is
issue.
Not most of this. It's not evidence based, but I will tell you.
Yes.
Number one, the phobia we had at that moment from the statements we told from this toxicology consultant. She told us that this is a grave prognosis actually, because it's very, very high dose of thiophelin. So we wanted to start very aggressively. So it came to our mind, especially from my junior colleague, is to start low and go slow, afraid from this what's called the dialysis disequilibrium and so. But it is not the issue, because it is not an osmol. I mean, it's not like urea or mannitol or something like this. So no need to afraid from the dialysis disequilibrium. So you can start. You can start the dialysis smoothly, as you said. The third point and the most crucial point, we don't have available in our hand, within our hand at that moment, this thiophelin level. Yeah, so we thought that we should start aggressively as much as we can, keeping eye on this electrolyte imbalance. We know that we can aggravate this electrolyte imbalance at that moment, but every hour we check this during dialysis. We check this phosphate and also the potassium. And what's in our hand at that moment, we try to correct potassium by IV infusion according to the level hourly during dialysis. Especially again and again, we don't have the thiophelin level in our hand. So it is a risk benefit at that moment. Maybe we don't have an evidence-based, but that's we sought in and we carried on at that moment. Do you have any comment, Dr. Muhammad?
If we follow the same pathway, we would already reach the same point. Previous cases ended with this. We wanted to change the pathway, and we were lucky. We reached another point.
Yeah. So that is what available in our hand. We start. It seems to be aggressively somewhat, but we were afraid from this toxic dose of thiophelin and its fatal consequences. That is our justification at that moment.
Okay. Thank you, Professor Said, for this heavily fruitful session, full of discussions and full of informations and full of to the point teaching points. And we can close, and let me thank all of your team, دكتورة هبة قاسم, دكتورة صفوة, and Dr. Muhammad Samir for these highly scientific, well-presented and well-prepared cases. And of course, thank you for leading this very distinguished team and preparing for us this very distinguished session, very fruitful session, as all professors said, Professor Manal Adib, Professor Tariq Tantawi, all before they leave us said that, and thank you for this very highly scientific session.
Thank you.
Excuse me to close, and before I close, I would like to thank our moderator today, Dr. Islam Abu Ni'ma, for his work and for his work with this session and all other sessions, and especially to stress that it was not his duty, but he was a volunteer to do this for us. And thank you, Dr. Islam, for your job. And excuse me to close and announce about the coming session, which will be by Professor Faisal Shaheen. He will speak about aging and the kidney, and we are expecting a very hot topic and a very fruitful session next Wednesday, inshallah. Thank you.
Thank you, Professor Yasser. Thank you, Professor Sobh, Professor Dawlat, Professor Manal, Professor Khalid, and all the Dr. Tariq, and all the great attendees. And in the meantime, thank you for you, Professor Yasser. And I should admit, I should thank my dear young sisters and brothers. I mean, Professor Heba, Professor Dr. Safwa, Dr. Muhammad. And thank you for you all. Thank you so much.
Thank you. صباح على خير والسلام عليكم ورحمة الله وبركاته.
شكرا جزيلا. السلام عليكم وعليكم السلام وبركاته. شكرا.